Thank you all for joining. So I'll be starting off with the first case. So I'm Kesley Pan. I'm a second year fellow at MD Anderson, and I'll be presenting a case of unresectable stage 3G lung cancer. So here we have a 67-year-old Caucasian female, never smoker, with history of stage IIIB adenocarcinoma of the right lung. Her NGS mutation EGFR L858R with a renal lung distance. And the question for this session was the panel is what would be your next systemic therapy of this application with insights for supervision plans. So the patient initially presented with 3 months of persistent cough, occasionally associated with low homoxis, otherwise pretty symptomatic. She had the different percolating status with the Mahaga 1. Her medical history is just remarkable for hypertension. She's a never smoker, uses alcohol occasionally, as well as drug use. She has no family history of cancer. Okay, so her initial workup started in January this year, where she tested 436% of the cough, showed a large 8 by 7 centimeter right middle mass extends to the hilum, compressing the right middle bronchus and encasing the right middle pulmonary vein. In addition, it showed a large right angular node that is ipsilateral, also right perpendicular node that's a Korean upper at large. The PET confirmed the hypermetabolic 10.5 centimeter diagonal mass. In addition, the subclinical lymph node is PET added. They detected no additional pulmonary nodules or distant metastases. EBITS biopsy of the right middle lobe mass confirmed lung adenocarcinoma, and an FNA of the station 7 lymph node refers to one that was PET added was positive for lung adenocarcinoma. Subsequently, this NGS with TENDIS, and was less than 1%, that detected a mutation in EGFR exon 1 L858R. And the rest of the target mutations, including KRAS, BRAF, ROS1, that and alpha
This. I use it not 50.
So the first thing we did was to present this case to NDC, where the patient was deemed unresectable, as well as T4 and T0, making it stage 3B, as well as had external compression, the right middle vein. So the treatment was recommended by the previous mutation. So very recently, we started concurrent radiation with carboplatin butyroxine, the planned duration of 4 cycles. And this PET unit is just per time right?
There was mass need, but
So the question for the panel is, what would you do next for contribution of chemovacation? And more specifically, given the backgrounding war trial presented at ASCO, which you will continue on development for MCC and Burn.
I have a question before that. Because you decided carboplatin pemetrexate. Is there a reason why those carboplatin selecting phytocystratic? Or is that a normal status? Be right back to that. Can it be studied more right size of that?
Yeah, so I think just concern due to age and I think her hearing. I didn't mention that she has any impaired hearing, so those are the mild concern of her,
and also why you choose the 4 cycle.
Yeah, 4 cycles for the duration of radiation.
Yeah, so usually 6 weeks or range. So most of these patients get 2 cycles, maybe at 3rd cycle. We're not overuse the consolidation like used to. But, maybe that relates, but you couldn't get stimulated and let's just keep it at that. You couldn't get stimulated and there's not enough machines.
We also have to start the chemo while the radiation.
Yeah, right. Yeah, so I guess you're still in treatment, right? It's plan, right?
Yeah.
And it's a valid question, right? So at the end of the final, who was to the verb? I won. But
Can I quickly ask, because this is such a big tumor, what
Yeah.
you want to comment on what are the effects of radiation such as oxygen on patient from toxicity standpoint, or good ability to achieve control and so forth?
Yeah, it'd be interesting to know the details of the radiation, typically essentially ready using the 3D control approach or the tensor modulated radiation IMRT approach. But it would be good to do number one, determine the response to therapy. Number 2, make sure that I think part of what your radiation oncology colleagues will do will be to look to make sure there's not an excessive dose to the lung itself, because that can happen when you have a large tumor. And even using IMRT techniques, there's not guarantee that that will not be missed. If someone likes to escalate the dose of radiation, a large tumor like that can be tough to do. And sometimes you have to work hard to get a good, so what's known as a V20 of the normal, the dose of the normal one, and get up to 60. Larry, if you have any other comments on it.
No, I agree completely with what you said. As our big year, or not, and escalate like maybe highlight was used within the fracture word itself, but not.
And I think that the important teaching point is, as medical oncologists, you should have an expectation that your radiation oncology colleagues should be able to get treatment going the second cycle. You get fundamental partner.
Yeah, always taught me to start treatment really fast.
Exactly.
These days, it's the insurance. Biggest issue.
That is true. That can be true.
They wait, they give a simulation, wait.
That's the question. So if we swing this door, like a 30%, people need to change. There's work and maybe wait. Maybe that's what they want to be for. I want to swing the door, I think maybe 30% so you can eat. That's what you need.
Well, the nodal target will not change. And if you think 20% just geometrically, if you really almost deal with a spherical tumor, it's not going to measurably affect the normal. So, I think, and again, if you start chemo and radiation at the same time, then you're doing post-chemo radiation chemo rather than doing, either Pacific or perhaps something of those.
And one of the concerns about doing that, right? If you made a decision to do carbo because of the age, we shouldn't make decisions for therapy based on age for most geriatric assessment. Because if the patient is already very older adult, you could do a lot of chemo up front and may not be able to tolerate the concurrent radiation. But it's quite challenging at the end for the patient. The first 3 weeks are okay, but the last 2 weeks we significant damage to the deteriorate. I never had a funeral wreckage. Even my 28-year-old I have right now, that's like, oh, I'm doing great. And we say, usually have the third of our life.
Now, even with chemo, we have to talk about this is one way of treating. There are other approaches to concurrent chemotherapy. The weekly paclitaxel regimen is probably the most commonly used regimen in the U.S. I think this is platinum-based regimens are preferable for younger patients. They want to be a little more aggressive. Their kidneys are really good, and they are running 5 miles a day like body does. Okay, do it. For the rest of the patients, I think if there are comorbid conditions, the weekly regimens ends up being a good. And we still have one which is better.
And the kind of the thing is at the end they struggle with fluids, right? So you see they're feeding for paraparsitic walls and also softer than fluid because they have a very hard time keeping on because of stuff they diabetes and many other regimens. Put it bad regimen, which is keeping on.
Yeah, and particularly this can be a cohort that it doesn't articulate big dehydrating to the metallurgy. So they get it in a take tracker with start corn.
Okay, what do you call patients in terms of the esophagitis in general when this is deep of TAFBD or serotonin or the field radiation?
Yeah, I think it probably has mostly to do with your nodal target, which is going to be generous on this one. So and it's also a technique that this patient is going to be a great risk in some of just
More or less 20%.
it's, if you look at the recent literature, the rates that were reported in Pacific and Pacific maybe following the concurrent studies where we registered patients before, it's more in the 12 to 15%.
It is unusual for me to break those trends.
Yeah.
You got to keep her small cell, that's what causing the cancer.
And typically, with the civic stages, consolidation within 6 weeks of completion, this is the patient who's going to push you that 6 to 8 weeks before it's better.
Yeah, I guess out of the stuff, so how question is if like a new child gets presented and it's after speaking, but not yet approved for approved at this time of the patient, we didn't know what to do. If you like try to get approved or choose the food to then refer. Yes.
We would say until it's grows now standard of care, and this is again not sort of actually deployed in the we should.
So we do know that for the syndrome analysis of AFib patients with EGFR mutations have non-molecular benefit from the myeloma. So prior to Laura, I think that some people know what I have partnered with were notes and there were EGFR, we have a lot of barbiturates, and we were notes with investigation. And we had our open which allows.
Well, I think we got to be fair to the patient also. The patient cannot really an argument to go to ignore the approval. I think also that most part are using the level of label. Of course, you could you can overcome label. But this is a rare, so they cannot put the patient on the blue bar. Waiting until the approval is in or the CI chain of lack of side with the patient. And unfortunately, it is not the only off-label thing that we do, but there are some things that have to be off-label.
I agree that with the PD-L1 being less than 1% of the mutation are often occurred by. My big concern with that with radiation treatment start taking PKI is monogamous, especially if you're doing it off-label. Right.
So from our practice, I either wait for it to be publicly presented, published in peer review article before I cut out for implication. But as a mind point of that, it's kind of quality check, peer review, and I think that's a fair thing. I don't really all treats that I available.
That's also like this is HPV. So what are the chances of this patient will be at 30%? Disease are the patient was die and the other that's why what does it cost the panel and I didn't go
We don't know that starting it as adjuvant or starting with partial progresses and then term. That's the best of the results. Is we still get the same message. We will just know.
And you need to know also how she responded, right? Because we're all, right, it hasn't made this like radiation yet. It puts anything forward. Yeah, so we need to know how she also responded. You have an opinion for so many people, and I think that just points to the art of apologies here.
Hopefully, we heard chemo rating out would settle.
So that this will get you out of this box.
What things will be different?
The only thing I want to say, based on the data that we have, I think that would be very tedious for this patient to put a patient on the value map. That patient, unfortunately, we have a recording that is a reality. We saw that in an hour. When you see that, that's why we continue losing patient. On the adjuvant setting of the patient, we take the fracture. And if you got a stage IIIB, those patients will be fractured. Okay, and you remove those investigative, and then those patients continue decreasing, that EFS continue going down after we stop post-investigative. So the worst thing we can do right now, based on what we have, is to offer the patient to value and that will be the incorrect answer. You watch the patient very closely. You build to left if you don't have an answer for the point that he made and he's correct. So because if you put a patient on Durva, then you will have a problem with the time to use those inherent costs. And then the patient may die from fatality from going from immunotherapy to TTK.
So there are a couple of points I can make without breaking any of the embargo requirements for of the Laura. One is, Laura is the first time we actually had longitudinal ability to look at EGFR mutated stage 3 mutations to see how they behave. But when you look at sporadic reports on outcomes for EGFR mutated stage 3 patients who treated with chemo RT, their risk of systemic failure appears to be much higher than patients without an EGFR mutation. Their risk of brain failure also appears to be higher. The second thing to Roger's point is the trial design for Laura, we prospectively put in for patients with control group, when they experienced disease progression, that they were offered osimertinib as part of the study provided intervention. So it does in some way answer the early versus late question. It's not because patients do get it and cross over.
Yeah. Any other comments from this side of the room?
It's a good case, you start with first, that's okay to back.
Yeah, for full transparency, this relocation at early stage, not stage 3. I made a decide now. Okay, so thank you so much for
Thank you.
all the wonderful discussion. And